Hello, and thank you for joining us. My name is Carlos Casano. I am a pathologist at Loma Linda University Health in Southern California, and I would like to present this project that was started while I was a pediatric pathology fellow at Cincinnati Children's Hospital under the direction of Dr. Jennifer Pekarsik. Now, the project is entitled Histiocytic Neoplasms with BRAF Rearrangements and Loss of CDKN2A, a distinct entity with uncertain malignant potential. This is our poster, which we would like to share with you. And just to start off, this was very much a multi-institutional collaborative effort with contributions from multiple different teams. Now, at its core, our project examines features, namely genetic features, of a set of atypical histiocytic neoplasms identified in children. Abnormalities in the MAPK or PI3K pathways have been described in histiocytic neoplasms, including BRAF mutations, but BRAF rearrangements, while they have been described, have been found less frequently, and less is known about them and how they impact both phenotype and clinical behavior of histiocytic neoplasms. With that in mind, we looked for cases of atypical histiocytic neoplasms that met certain criteria, namely having a non-LCH immunophenotype and a BRAF rearrangement. And we took a further step of looking for cases that had loss of expression of P16, indicative of loss at the CDKN2A locus, which encodes an important tumor suppressor gene that is involved in cell cycle pathways. We identified, based on these criteria, 7 histiocytic neoplasms of interest. The patients included 3 females and 4 males, ranging in age from 6 months to 22 years, and BRAF was rearranged in every case, but each fusion partner was unique, so we did not see the same fusion product in any of the 7 cases. Morphologically, the cases showed atypia beyond what would typically be expected in juvenile xanthogranuloma family spectrum. The findings included epithelioid morphology with a range from low to high-grade nuclear atypia, as well as variable neutrophilic infiltrates that were more prominent in cases with greater nuclear atypia. Immunohistochemical staining was positive for at least 2 macrophage markers. Cyclin D1 and pERK were positive when performed, and factor 13A had variable expression. But Ki67, which provides an index of proliferation for the neoplasm, was highly variable in these cases, ranging from about 10 to 70%, and at times showing discordance with the degree of nuclear atypia. Other stains, which are listed there, were negative. Now, our results are shown here. Which includes H&E images and images of Ki67 immunohistochemical stains. We'll take a quick look at these cases. The first 2 cases were in a 1-year-old male and a 6-year-old female, and the first case was a soft tissue inguinal mass, the second a brain tumor. Both of these were called atypical histiocytic neoplasms with uncertain biologic potential, and we should point out that the first case was initially diagnosed as a malignant histiocytic neoplasm. But if we look at the morphology for these cases, we see a largely epithelioid morphology, a bit of spindling in the second case, but without significant cytologic atypia, and with Ki67 proliferative indices of 15 to 20%, with the higher one in the second case. Looking at the next 2 cases, cases 3 and 4, both of these are bone lesions in a 12-year-old and 6-month-old patient, and both were also called atypical histiocytic neoplasms with uncertain biologic potential. We do see a bit more cytologic atypia in these cases, especially in case number 4, as well as a few more granulocytes infiltrating the lesion, but there's a bit more of a discordance with the Ki67, with case number 3 showing a proliferative index of about 40% compared to 15 to 20% in case number 4. Cases 5 and 6 were both lower extremity soft tissue lesions in a 15-year-old and 11-year-old patient, and both of these were called malignant histiocytic neoplasms, histiocytic sarcoma subtype, but with indolent clinical behavior. And we do see much more prominent cytologic atypia and neutrophilic infiltration in these 2 cases, but again with some discordance with the Ki67, with case 5 showing 15 to 20%, and case 6 showing 35%. Case 7 was unique in that it was a 22-year-old patient who had started having lesions around the age of 12 and was found to have a germline biallelic CDKN2A deletion with a cancer predisposition syndrome. The most recent cases involved the lung, which showed a malignant histiocytic neoplasm with a concurrent skin lesion. And this one had much more prominent cytologic atypia, neutrophilic infiltration, and a very high proliferative index in the lung of 60 to 70%, but much lower at about 15% in the skin, which we do not have a picture of here. Overall, and in summary, What we found is a series of histiocytic neoplasms with BRAF rearrangements and inactivation of CDKN2A with features outside of what would be expected in a typical juvenile xanthogranuloma family lesion. Ki67 proliferative indices were discordant and there was variability in clinical behavior, and we propose that for these atypical histiocytic neoplasms, investigation of genetic features including searching for potential mutations, gene rearrangements, and evidence of loss of CDKN2A is important not only to learn more about disease biology and progression, but also to better understand prognosis and develop new targeted therapies. And given the atypical features demonstrated by these neoplasms, we propose that they may constitute a distinct entity of histiocytic neoplasms with uncertain malignant biologic potential, or HUMPs. Further investigation with longer clinical follow-up is needed. We hope that the cases presented here provide a starting point for further studies, and if you encounter similar cases in your clinical practice, we invite you to collaborate with us by contacting Dr. Jennifer Pekarsik at the email listed here. Thank you for your time, and we hope you have a nice day.